If you're sending even 3 detox-eligible patients a month to the hospital, you're probably lighting around $60,000 on fire every month. 3 patients at roughly $20,000 each in lost and replacement revenue. And most of those patients never come back to you. In this 10-minute case study, I'm going to show you how treatment centers like yours are turning that hidden loss into a high-margin medical revenue line without building a hospital and without burying your staff. If you run a treatment center or clinic that already has steady admissions but no in-house detox, this is for you. So, what do you do right now when a patient clearly needs detox? Most centers do one of 3 things. They send the patient to a hospital detox, they refer them to another program they trust, or they quietly turn them away and hope they come back later. Here's what the data actually says. When you send patients out for detox, about 77% never return to your facility for treatment. That means you lose the clinical relationship, the downstream treatment revenue, and you often end up competing against the very place you sent them to. By the time you factor in what you could have earned from their treatment episode, plus what it costs to replace that patient, each non-returning detox patient can represent $17,000 to $21,000 or more in lost revenue, and up to $30,000 in replacement cost. Quick example, out of 20 new admissions in a month, say 10 qualify for detox. If you send those 10 out, you will lose around 7 of them, on average, to competing centers. You funded the front end, they reap the back end. Now flip it. Instead of sending them away, you run ambulatory detox in-house with a protocol insurers actually like to pay for. We built our model around a conservative $425 per day per patient. That's based on real Medicaid baseline numbers, not theory. Here's the simple version of what that looks like. At 3 detox patients per week, you're around $38,000 per month. At 5 patients per week, about $64,000 per month. At 10 patients per week, about $127,000 per month from detox alone. And that's before dual billing. Once an opiate patient stabilizes, usually day 5 or 6, they can move into residential or intensive services while they're still in the detox protocol. At that point, insurers are paying roughly $1,125 per day. $425 for detox, plus $700 for residential, for the same patient on the same day. So instead of losing those patients and that revenue, you're stacking a high-margin medical line on top of work you already do. Money aside, here's the clinical reality. Myth 1, detox is a necessary loss center. You do it for altruism, not outcomes. In a traditional inpatient model, insurers usually authorize 5 days for opiate detox. But secondary withdrawal lasts 2 to 4 weeks. So patients leave the unit after 5 days, still feel awful, and they walk out AMA or they relapse before ever completing treatment. Ambulatory detox fixes that. Instead of a 5-day cliff, you run a 20 to 30-day structured protocol where patients are checked on daily. They stay engaged with your team. They transition straight into IOP or residential while still in protocol. They've already met your staff. They already know your building. They're through the worst phase of withdrawal while they're still connected to care. AMA rates drop, completion rates go up, long-term outcomes improve. And this isn't theory. One of the early programs built on this model has been running 4 years. When we asked the owner what it generated, the answer was, "I'd have to pull the exact report, but it's in the millions." Here's where most owners get stuck. Myth 2. To do detox, we'd have to build a mini hospital. We can't handle that. That's true for traditional medical detox. Oxygen lines in the walls, crash cart, hospital beds, 24/7 nurses, a $15,000 a month medical lease. It's a break-even at best. Ambulatory detox is different. The minimum requirements to do this properly are space, 2 offices, a waiting room, and a private bathroom for testing. Most centers already have it. Staff, a part-time doctor, a part-time nurse practitioner, a part-time nurse, and a part-time therapist. No oxygen, no crash cart, no medical beds, no new building. And the implementation is a simple 4-step process. Assessment. We map your current program, licensing, EHR, and staff. Setup. We install protocols, training, and billing structure into the stack you already use. Launch. Your part-time medical team starts seeing detox patients. We walk beside you. Optimize. We monitor billing, compliance, and operations so the model gets tighter over time. Now the real objection. Myth 3. Even if the numbers work, my team can't handle one more complex program. In our experience, that's why most centers say no, not because of the price, but because the owner or the person running the business side is already maxed. So we built the business infrastructure into the offer. Underneath the clinical protocols is a training and reporting platform that does 3 things for you. You always know if staff are following protocol. Patients complete a daily form. Nurses, therapists, and providers have their own steps. If someone skips, it shows up in the dashboard. You always know if payers and billers are paying correctly. We track contracted rates versus what you actually get paid. Watch underpayments and claims aging, and monitor third-party billers so you can see if they're leaving money on the table. You are always audit ready. Documentation, KPIs, and checklists are organized in one place. So if an insurer shows up for a take-back, you're not scrambling. You can hand them the system and be done. This isn't cool AI features. This is, you don't have to build a finance, billing, and compliance machine from scratch to make ambulatory detox work. AI needs structured data to work. Our ambulatory detox protocol and reporting system create that structured data foundation from day one. So AI can actually drive reporting, compliance tracking, and operational intelligence instead of just being a toy. Most companies right now are charging thousands for AI consulting, delivering generic dashboards that don't tie into real workflows, shipping features that sound good but don't change day-to-day operations. Your EHR probably already has some AI. Note generation, documentation assistance, smart charting, useful, but it doesn't run your clinic. What we've built is AI that runs the back end. Protocol tracking, plus billing, plus compliance in one place. Live dashboards with 60+ KPIs that update automatically. An infrastructure that lets us expand with new agents over time as your operation grows. Within the next couple of years, the centers that aren't implementing AI into their operations are simply not going to be competing. This is the first practical step in putting AI into the back-end processes of your program in a HIPAA-compliant way. This isn't cool AI features. This is, you don't have to build a finance, billing, and compliance machine from scratch to make ambulatory detox work. Last belief we have to break. Myth 4. Insurers won't really pay those rates. We'll fight them all day. A medical director from a national carrier who has worked with Mike for over 10 years put it like this. I'm familiar with Mike's role in establishing and advocating for this level of care. I trust the program he has created. We're contracted with an ambulatory detox center he helped set up, and it's been successful. We have a great partnership with that center. They don't talk like that about programs that nickel and dime them. We also have written confirmation from major carriers that this exact protocol is billable and reimbursable at these rates. When you follow a structured, ASAM-aligned protocol with daily monitoring and clean documentation, you're not asking for a favor. You're delivering the level of medical service they're willing to reimburse at higher rates. If you're already seeing consistent admissions and you're tired of sending detox patients and all that revenue out the door, here's the next step. We call it an ambulatory detox growth map session. On this 45-minute working session, you and your leadership team will get a custom 12-month revenue projection based on your actual census and conservative payer assumptions, a clear pass-fail feasibility check on licensing and staffing in your state, a loss report on how much you're currently leaving on the table by sending patients out, a draft implementation timeline you can take back to your team. If the numbers don't pencil out or the licensing doesn't work where you are, we'll tell you in the first 15 minutes and end the call. No pitch. So your real choice is simple. Get a concrete map for your program or keep guessing about the numbers. If it does make sense, we'll show you what it looks like to have us install the whole thing with you. Click the button below, pick a time, and let's see what ambulatory detox would actually mean for your program.